Hello, it's Mark Kris from Memorial Sloan Kettering. And I have been thinking lately about treatments after initial therapy for non-small cell lung cancers. Uh, People often call it second-line therapy, and some thoughts there. I think the first thought is that all the regimens that are available and tested, the results are clearly not as good as seen with first-line therapy. And I'll get into some specifics in a second. So that being the case, it's really, really important to make the best choice for first-line therapy. The second thing that is absolutely critical is that you very carefully assess when that first-line therapy has stopped working, when there is a need for a new systemic therapy. Number one, we very often have these situations where there is a oligoprogression, and by treating a single symptomatic lesion, you may again get the patient in a very good place, and you could continue initial therapy. And very often, there is a inconsequential growth of the cancer. So, for example, a 21% increase in the size of a primary tumor that is not associated with any symptoms in a person who is living their life and a person who is not having any severe side effects, you have to think long and hard about changing that therapy. Obviously, you don't want to change that therapy, and I wouldn't even give a consolidative therapy there if they're really doing well and fine. Obviously, consolidative therapies are a new therapy and they have their side effects with them as well. So please think really carefully and weigh all factors from the patient, the toxicity, the benefit, before changing the initial systemic therapy. And I would continue it as absolutely long as possible. Now, second-line therapy, sadly, none of them have a huge benefit anywhere near what we see in first line. All of the rates of response are well under 50%. So, just getting into it, you're not going to shrink the cancer by more than 50%, by more than 30% rather, in the majority of patients. So you have to think long and hard about making that switch. Secondly, our standard still remains a docetaxel, and the numbers on docetaxel, they're really not great. It's about a 15-ish% rate of response, and about a median survival of about 5-ish months. Now, by adding other drugs to docetaxel, you can achieve better results. And adding ramucirumab, for example, the response rate just about doubles. The duration of response and progression-free survival go up by a few months. And for patients that have KRAS G12C, in the randomized trial that has been done so far, over docetaxel, you get, again, a doubling of response. So for patients where response is important, you really double that response rate. But also, you get an improvement in median progression-free survival by, again, a couple or 3 months. So there is benefit there in terms of response and progression-free survival. However, it's not huge. So, also, please remember, if you're choosing to use docetaxel, to think about using alternative dosages and schedules. When you look at the course of a person treated with docetaxel over let's say, a 6-month period, I see you often see doses are held. And when you look at the total dose, it's very similar to an every 2-week dose of a lower amount. I routinely give a 60 milligram flat dose every 2 weeks, and I urge you to look at the progress of one of your patients over a 6-month period that was given the 75 milligram dose, and a lot of those doses end up getting held. And when all this said and done, you give a lower dose over that whole time from that 75, and giving for like 35 per meter or a 60 milligram flat dose every 2 weeks, you end up getting almost exactly the same amount of docetaxel. And there's really no convincing evidence that the higher dose is better. It's clearly harder on the patient. So some thoughts about second-line therapy. We really got to do better. Please make sure that your first-line therapy is the best you can give. Make sure you've gotten everything out of that first-line therapy, that it be continued as long as possible, as long as you and the patient have concluded that there's benefit. And when you do switch, try to give the most effective regimen that you have, and that would be docetaxel with ramucirumab, or for patients with KRAS G12C, giving adagrasib or sotorasib at this point.